Okay, let's make a start there. Good morning, good afternoon, good evening, everyone. My name is David Winterflood, and I am the CEO of No Man is an Island Race to End HPV. And it's my pleasure to welcome you as your chair to today's webinar session. It's on the screen, Boys, Men and HPV, call for global gender-neutral vaccination. We can have the next slide, please. Just to kick off some housekeeping, please do introduce yourself in the chat. Let us know your name and the organization, where in the world you're joining us from. Within that chat, you can ask questions. Do ask those questions in the chat today. You can make comments about what you're hearing, share your thoughts, and take part. We have 60 minutes. And just to note that the session will be recorded. So if you do want to revisit aspects from today, you will be able to do so. Why have we brought you together for this webinar? If we can have the next slide. As many of you are aware, NOMAN and Global Action on Men's Health are working together to make the case for global gender-neutral HPV vaccination in order to secure a HPV cancer-free future for both our daughters and our sons. And we launched a new initiative at the World Cancer Congress in Geneva just a few weeks ago. Most likely, a lot of you will have missed that, but today we're going to consist of two parts. First and foremost, Peter Baker from Global Action on Men's Health will run us through the presentation of our case for global gender-neutral HPV vaccination. And this will be followed by comments and discussion with two experts in the field. And we hope to have time for questions and comments from you following that. But without further ado, Peter, I hand over to you. Let us know the case for action.
Thank you very much, David, and hello, everybody. It's a pleasure to be here and to talk to you about global gender-neutral HPV vaccination. In the next 20 minutes or so, I'll try and explain why we think it's time for a change in global policy on this critically important public health issue. As David has already said, this initiative is a joint one between Global Action on Men's Health and No Man is an Island. And both organisations have been involved in this issue for some time. And if I can just speak personally for a minute, I've been an advocate for gender-neutral vaccination for about 12 years now. And I started this work in the United Kingdom, where I worked with David and headed up the HPV Action Campaign, which was a coalition of about 50 civil society and professional organisations, which successfully persuaded the UK government to introduce gender-neutral vaccination. It took us 5 years. It wasn't straightforward. We had our ups and downs, but we got there in the end. And I'm pleased to say that in the country I live in, the United Kingdom, boys have been vaccinated alongside girls since 2019. I then worked with the European Cancer Organisation to take this issue into Europe, and we helped to persuade the European Union to adopt gender-neutral vaccination as a flagship policy in Europe's Beating Cancer Plan. And I will say more about developments in Europe a bit later on. But I think now it's time to take a global perspective on this issue. Before I move on, I want to quickly thank MSD, AAA and NOMAN. AAA is a Novartis company. I'd like to thank those three organisations for supporting Global Action's work on men, cancer and HPV. And I think it's important that I add that neither MSD or AAA have sought or had any influence on our policy work on this issue. So this is our policy report, which sets out our case for global gender-neutral vaccination. As David has said, it was launched at a special meeting at the World Cancer Congress in Geneva last month. And you can download a copy from our End HPV global website or by using the QR code, which is on the screen now. But I will put the link to the report in the chat after I finish speaking, so you can take a look at it after this webinar. Here you can see the organisations which have so far committed themselves to supporting our call to action. I hope you'll agree it's quite an impressive list. There are 26 logos on the screen. In fact, since I prepared this slide, the numbers increased to around 30. So we're getting new support, new commitments of support week by week at the moment. If your organisation is on the screen, we thank you very much indeed for your support. And if your logo isn't on the screen and you'd like to work with us on this issue, please do let us know. We'd love to hear from you. So please do get in touch, and the contact details, our contact details, again, we'll share those later in the webinar. So just to put some context about why we as Global Action on Men's Health are involved in this issue, and it really forms part of our work on men and cancer in general. And we're interested in men and cancer because there is a very clear excess burden of cancer on men. Globally, a man has a 1 in 5 chance of getting cancer by the age of 75, and a 1 in 10 chance of dying from cancer. That's any kind of cancer. But if you look at all the cancers combined and compare men and women, then men are 15% higher. Incidence rate for men is 15% higher than it is for women. And the mortality rate is a staggering 43% higher. And you can see in the diagram there how the mortality rates in men and women compare for many of the more common cancers. And you can see perhaps the difference is most stark for lung cancer, where you can see that men are much, much more likely to die than for women. But for all those cancers, the top 15 cancer sites, men have a higher mortality rate than women. Why is this? Why do men suffer this excess burden? Well, partly it's down to biology. We can't do very much about that, but we think, we're not exactly sure what the biological differences are, but it's likely that men have fewer tumor suppressing genes than women. And although we might not be able to change the biology, what it does mean, of course, is that we need to do more to detect cancers early in men so outcomes get better. But there are other factors that are perhaps easier to change. We know that part of the reason for the excess burden of cancer in men is that men are more likely to smoke, to drink alcohol excessively, to have a poor diet, to expose themselves to the sun without protection, and so on. Generally speaking, men also have lower symptom awareness. So when something does go wrong, they're less likely to be aware of what the problem is and to take action to sort it out. There are barriers to accessing primary care services. Of course, these barriers affect both men and women, but for men, there's two kinds of barriers really. One is a kind of psychological barrier, what's going on inside men's heads, where there's, because of the way men are socialized, often a reluctance to ask for help, but also there are practical barriers in terms of when services are available, and that's particularly a problem for working age men. We know that men have more limited access to cancer screening services, and the most common cancer screening service, certainly in high-income countries, is bowel cancer screening. And even though men are more likely to develop bowel cancer than women, they're less likely to take up the offer of screening. And part of the reason for that, we think, is that the screening service, bowel cancer screening service, is often not marketed effectively to men, so they're less likely to use it. And prostate cancer screening is available at the moment only in a handful or less than a handful of countries. Men are more likely to be exposed to carcinogens in the workplace. And this is the last point, which is of particular relevance to us today, men often have poor access, or generally have poor access, to cancer-preventing vaccines. HPV is one of those. The other is hepatitis B vaccination. Men are more at risk of hepatitis B, which can cause liver cancer. The women are more likely to develop an infection and to develop a hep B related cancer, but they're less likely to be vaccinated. And also we find that when you look at cancer policy, and we took a detailed look at this last year and published a report on the way men are treated in cancer policy at the global level, that we find that men are largely overlooked in global cancer policies. So those are all the reasons why we think men suffer an excess burden, but we can do something about many, if not all, of these factors. But if you want to find out more about our policy on men and cancer generally, please take a look at our Charter for Action report that was published in Men's Health Week in June this year. And again, there's a QR code on the screen, which you can use to download it. And I'll also share the direct link in the chat later. So turning to HPV infection specifically, what are we saying about HPV? Well, the first key point is that we now have the technology to protect everyone from high risk, that means cancer-causing HPV infections and the cancers they cause. We know, of course, that HPV also causes genital warts and RRP, recurrent respiratory papillomatosis, which are very nasty diseases, particularly genital warts. Genital warts won't kill you, but they're very difficult to treat, very unpleasant. They have psychological impacts on people affected by it, and they're expensive for the health service because often they keep on recurring. We also suspect that HPV may cause male infertility and cardiovascular disease in women, but today I'm going to stick to cancer. And HPV vaccination is probably the easiest way to prevent cancer, to stop people smoking, to limit their alcohol intake, to bring about weight loss. These are very difficult things to do, particularly for men. But we can protect everyone against HPV in a few minutes, actually a few seconds. That's how long it takes to inject somebody. And we can do that with a very safe and highly effective vaccine. 5% of all cancer cases worldwide are caused by HPV, and they can all be eliminated by vaccination. We have the means to end almost every case of cervical cancer, most anal cancers, over half of penile cancers, and up to 3/4 of oropharyngeal cancers. That's a big prize, but it's not like a lottery prize, which is won by maybe one person out of 10 million. It's a prize that everyone can actually win. But to do this, we need a more ambitious, ethical, and equitable approach to HPV vaccination. And this means prioritizing the elimination of all the cancers caused by HPV and considering all young people, not just girls, but boys too, as a primary target for vaccination. And that's why we're calling for global gender-neutral vaccination by 2030, not tomorrow, 6 years' time, or 5 years' time really, with a 90% uptake goal for everyone. 90% is the level at which the community as a whole is protected against infection. So, why do we need to vaccinate boys specifically? Well, men are the main vector. That means the main carrier and transmitter of high-risk HPV infection. And I think this next statistic is pretty staggering. At any one time, 20% of men have a high-risk HPV infection, and that rises to about 24% in Africa. That's a quarter to a fifth to a quarter of men are currently infected by a high-risk HPV. That's cancer-causing HPV. This is a much higher rate than in women, and also men are infectious for far longer than women. In fact, the infection rate is pretty steady across the male lifespan. Once men reach adulthood, they continue to be infected with HPV, high-risk HPV, at pretty much the same level throughout their lifetime. And that's very different from women, where the infection rate tends to drop from the mid-20s onwards. Men naturally clear the infection far less effectively than women. And that's why Professor Harold Zerhausen, the man who won the Nobel Prize for establishing the link between HPV and cervical cancer, suggested that if just one sex is vaccinated, it should logically be boys. He was, I think, being facetious, and I'm certainly not advocating a boys-only vaccination, but he was making a very interesting and important point. Rates of penile and anal cancer are now rising significantly in men, and there's recently been particular concern about a big rise in penile cancer cases in Brazil. And HPV is the main culprit here. In at least 2 countries, the United Kingdom and the United States, the incidence of oropharyngeal cancer in men has overtaken the incidence of cervical cancer in women. And this is being driven by HPV. And we also know that the number of HPV-caused cancer cases in men has been seriously underestimated. We know that about 20% of HPV cancer cases in India are male. And on the screen, you can see that in France it's 28%, Spain 30%, Denmark and Ireland 35%, and in the United States 42%. So 42% of all cancer cases, HPV cancer cases in the United States, are in men. So to try and get an idea of how many cases, HPV cancer cases, there are around the world, we don't know for sure, because recording is not good in every country. But if we look at 5 countries where there is good data, including 2 very large ones, the United States and India, we can estimate that HPV is probably causing around, or in fact over, 180,000 cases a year around the world, probably more than that. And we've calculated this in a very straightforward way. You don't need a degree in mathematics to see how we've done this. In those 5 countries, there are 42,500 HPV-caused cancer cases. And in those 5 countries, there's 23% of the total global male population. So if you gross the figures up to 100% of the population, you get a figure of over 180,000. There are also no screening programs available for men. So there's nothing like the cervical cancer screening program, which is now available in many countries. So these cancers are often not detected early in men. And obviously that means that the outcomes are likely to be worse. We also need gender-neutral vaccination, because girls-only vaccination programs cannot fully protect women. So even if 90% of women were vaccinated, and we're a long way from that globally. In fact, there's just 1 or 2 countries where the rate has at times exceeded 90%. So even if we hit the 90% target, millions of women would still be at risk from unvaccinated men. So we can see that even if the only cancer that we were interested in was cervical cancer, vaccinating the boys as well would accelerate the elimination of cervical cancer. And girls-only programs cannot fully protect men, especially men who have sex with men, because that group is completely unprotected by a girls-only program. And men who have sex with men are at particularly high risk of a cancer caused by HPV. So girls-only programs also can't eliminate all the cancers caused by HPV, and modelling suggests that HPV could be eliminated in 30 years with gender-neutral vaccination, even at 75% coverage. And I think it's important to add at this point that the debate about HPV vaccination shouldn't be one that pits men's health against women's health. This isn't a zero-sum game. We need to vaccinate both boys and girls, and that would mean that everybody wins from vaccination. Okay, there are several other good reasons for introducing gender-neutral vaccination. First of all, it can increase the resilience of vaccination programs. Unfortunately, we have seen that vaccination rates can fall if there's a collapse in vaccine confidence, often because of a safety concern. And that's happened in Ireland, Denmark, and Japan. And it takes a long time to recover from those falls in confidence. And vaccination rates can also fall because of things like a pandemic. We saw that during COVID, war, or natural disaster. But if a higher proportion of the total population is vaccinated, this helps to mitigate the impact of a fall in uptake. Gender-neutral vaccination defeminizes and destigmatizes vaccination programs. We think that girls-only programs perpetuate the myth that sexual health and health generally is primarily the responsibility of women and girls. Of course, it's not. And girls-only programs can also help to perpetuate a belief that women are somehow to blame for HPV. But gender-neutral vaccination, on the other hand, shares the responsibility between the sexes and genders, and may even help to boost female coverage, as has been the case in Cameroon recently. And we'll be hearing shortly from a speaker from Cameroon who can say a bit more about that. And a change in policy is now entirely feasible because the World Health Organization, WHO, is recommending single-dose vaccination programs, which makes them cheaper and easier to deliver. And it should also be noted, and here I'm very grateful to my colleague, Professor Giampiero Favato from Kingston University in London. It's important to note that not introducing GNV, gender neutral vaccination, and failing to eliminate HPV cancers creates a cost in perpetuity that is even greater for low-income countries because of their growing populations. In other words, if we don't eliminate the high-risk HPV cancers through vaccination, through gender-neutral vaccination, every country, even countries that achieve the 90% target, will have to carry on vaccinating forever to protect their populations against HPV infection. We have to deal with this as a global problem through vaccinating everyone. And global vaccine supply has improved rapidly too. There are now 5 vaccine manufacturers, and the supply constraints that applied a few years ago no longer apply, and supply will certainly not be an issue by 2030. So it's not just us who are supporting gender neutral vaccination, and it's not just the organisations whose logos I showed you earlier on. Gender neutral vaccine is now European Union policy and is recommended for all 27 member states. And in fact, every member state, all 27 of them, have either already introduced gender neutral vaccination or are committed to doing it in the near future. 4 African region countries have or soon will have gender neutral vaccination, with Eswatini coming on board with a program starting next year. In fact, around the world, 70 countries have now implemented gender neutral vaccination. That's about half of all the countries with vaccination programs. So we are making progress, but there's still a long way to go. And there's another 50 countries with no HPV vaccination programs at all. And significantly, of course, as you might expect, most of the countries with gender neutral vaccination are high-income countries, not all, but most, which creates a new inequality as the lower income countries fall even further behind in terms of the effectiveness and impact of their vaccination programs. So if we're serious about achieving universal health coverage and tackling non-communicable diseases, if we're serious about health equity, we need to protect everyone. So just to conclude, we think the evidence for global gender-neutral vaccination is now robust and overwhelming. The time for action is now, and so I'd be delighted if you could support our call for global gender-neutral vaccination by 2030. If you want to find out more, please read the report. As I said, I'll put the link in the chat in a minute, and take a look at our new website, endhpvglobal.org. And if you agree that both boys and girls should be vaccinated wherever they happen to live, please support our call to action. Thank you very much.
Thank you, Peter. A very compelling case that you made this afternoon. With that, ladies and gentlemen, it's my pleasure to introduce our panelists. They are Salomé Meyer from the Cancer Alliance, South Africa, and Dr. Brice Edzoa Essomba from Cameroon. Welcome to you both. Salomé, if I can direct some questions to you, first of all, could you set the scene for us what the current HPV prevention scenario is in South Africa? What's working well, and what are the challenges that you're facing?
So in South Africa, we started with the vaccination of girls only in 2014. So we are 10 years old. And in fact, we were quite successful, I think, with our vaccination strategy. And the reason for that is that we have a school-based vaccination program, which then means that you really have that access to the girls between the ages then of 9 and 14. However, as we all know, with COVID, COVID affected our vaccine rates as well, and therefore our vaccine rates dropped. And specifically because of COVID, you also have the situation that there's a lot of myths now going around with regards to the whole issue of vaccines and immunization. So that is in essence also impacting South Africa. What we have now is obviously our school-based program has resumed, and with the fact that we've changed over from the two dose to the one dose, we are now able to, as of this year, and it's in fact right now, October, November, we are able to then, with that savings, starting to focus on girls in private school, because previously they had been excluded because we only focused on the girls in public schools. So we're hoping that with the new, as well as a catch-up strategy, that we can go back to the 85% of a vaccination rate of our school-based girls. And that is in fact quite excellent. And I also would like to share that in terms of funding, our funding is a very dedicated grant that comes from Treasury, and that is then for the vaccination for HPV.
Thank you. I mean, you and I have spoken previously about the notion that women disproportionately shoulder the responsibility for HPV, and that can be linked to societal expectations shaped by the patriarchy, such as blame, sexual responsibility, the medicalization of women's bodies, and public health messaging. How has that impacted and shaped prevention in South Africa?
I think we need to start looking at what are our cervical cancer rates in South Africa, very particularly, but not only cervical cancer, what are all our other comorbidities? And this is where we then need to start saying and look at it from a broader perspective. So if you start looking at the fact that we have got very high number one, teenage pregnancy rates, we've got very high gender-based violence rates, and then if you go to anogenital warts, I mean, that is extremely high in our communities. Yes, and the other comorbidity that we do have is a very high HIV prevalence. So when you start looking at all those factors, you really then need to look at what is it that you are then promoting when you are focusing only on girls. And within the patriarchal system that we have in our country, and we need to look at the rural communities and where it is sometimes very difficult to reach people with regards to services, whether it be for screening, whether it even be for vaccination. How are you actually impacting the communities in terms of the future and future health? And that is why the whole notion of gender neutral vaccination is just from a overall health systems perspective, it just makes sense.
I mean, it's so. Do you want to tell us that? So why do you think personally that South Africa should move to gender neutral immunization?
My first reaction is, number one, South Africa has gotten, we believe, and we say it all over, is that we've got a very modern constitution where we are, in fact, we do not discriminate. So we do not discriminate in terms of sex, and also, so your sexual choice is your choice. So why then would we exclude men from the position that they could also benefit from a vaccine that could, in essence, protect them in future? And that for me is number one from that perspective. If we start looking at the whole aspect of anogenital warts, so when you start focusing on the bivalent vaccine, bivalent does not protect you against genital warts. And genital warts in our South African society, as one of our gynecologists indicated, is becoming the bread and butter surgery for our young people. What are we doing? And because of a continual reinfection, the poor young people have to go continuously for surgery. So we are maiming our young generation, and we are causing severe mental health problems. So if we haven't even quantified that aspect of HPV, let alone all the others. And that is absolutely for me one of the most compelling reasons why we really have to start focusing on gender neutral vaccination. We have got the ability to do that, and we shouldn't allow that affordability actually impact whether we save our young people. If we look at which countries have already moved away completely from bivalent vaccines, it's the countries that could afford moving to the quadrivalent as well as the 9-valent vaccine. And that is why affordability is a matter also of access, and that's what we need to start talking about.
Thank you, Salomé. Some excellent points. I think that what you're talking about in terms of looking at that broader picture, the importance of looking at the broader picture when we talk about HPV and its prevention, I think that segues us very nicely onto you, Bryce. Cameroon, could you share what was the justification of moving to gender neutral vaccination in Cameroon?
Good morning, good afternoon, good evening, everyone. It's a great honor for me to be part of this esteemed panel. I would like to thank, first of all, Global Action for Men's Health and NOMAN for organizing this vital webinar. I appreciate this question. And before diving into the details, allow me to set some context for our decision. In Cameroon, we initially began by vaccinating girls against HPV as a part of our national immunization program in October 2020. We used a tetravalent antigen. This fundamental step helped us to address cervical cancer among women and set a stage for expanding our approach to a gender-neutral vaccination strategy. So the decision to switch toward gender-neutral vaccination again, HPV in Cameroon, was driven by a recommendation from our National Technical Advisory Group on Immunization Lifetime. And the rationale behind this move is based on 3 key factors: equity, public health impact, and the scientific evidence from global studies. Firstly, focusing exclusively on vaccinating girls created an inequitable situation. While the primary objective was to prevent cervical cancer in girls, we must acknowledge that HPV also poses serious health risks to men, such as cancers of anus, penis, and oropharynx. By limiting vaccination to girls only, where we were missing a crucial opportunity to comprehensively tackle HPV-related diseases. Secondly, expanding vaccination to include boys is essential for strengthening herd immunity. Global studies have shown that vaccinating both boys and girls significantly reduce HPV transmission in the population. By vaccinating both genders, we can better protect unvaccinated individuals and reduces the overall disease burden. And lastly, the last argument, the decision to include boys was informed by a strong scientific evidence from international research. Studies conducted in countries like Denmark, India have demonstrated that HPV vaccination led a substantial reduction in cervical and non-cervical cancers in both men and women. Although these findings are not exclusively from Cameroon, they provide a robust evidence that a gender-neutral approach is both effective and necessary. Over to you, David.
Thank you, Bryce. It's interesting because, you know, in the global context or in the African context, Cameroon would be one of the outliers, as it were, as a country that is undertaking gender neutral immunization. Could you tell us what some of the challenges are for the HPV prevention program in Cameroon?
So thank you once more again for this very important question. So the implementation of gender-neutral vaccinations against HPV in Cameroon has come with a set of challenges, as you can imagine. One of the primary barriers we faced was the lack of financial support, specifically for vaccinating boys. While fundings for vaccinating girls was supported by external partners, the extension to boys requires additional resources, which had to cover mainly through the domestic funding. This created a financial strain and limited the scope of our program. This was the first challenge. The second challenge it was the insufficient community awareness regarding the need for vaccinating boys. Our initial communication efforts focused primarily on informing and educating families about the benefit of birth, leading to a knowledge gap when it came to boys. This lack of targeted messaging made it difficult to convince parents to vaccinate their son, especially when existing cultural belief did not associate HPV-related disease with men. And moreover, we face logistical and infrastructure constraints, particularly in the rural and hard-to-reach area globally. Delivering vaccine to remote regions, maintaining the cold chain, and reaching children who were not a part of a formal school system poses significant hurdles. This requires innovative outreach strategies and continuous coordination. Lastly, there was a notable challenge with vaccine hesitancy. Rumor and misinformation about vaccine effects on male fertility, coupled with a general lack of information targeted parents, boys, contributed to the reluctance. Overcoming this hesitation requires clear, transparent communication and the active involvement of trust community leaders. Over to you.
Just on that note, I think that's really interesting. Obviously, in terms of you know, the opportunity provided by gender neutral vaccination, but obviously that then throws up new challenges in its wake in terms of the need to re-educate people around HPV and all these diseases caused by HPV, but also these newer logistical challenges as part of it. Is there an observed observation in terms of what the impact has been on girls' coverage rates? So by introducing boys into the program, what has been the impact? Has there been an impact on girls and the immunization?
Thank you for the question. Before I discuss the impact, I would like to highlight some of positive signs we have observed since the introduction of gender vaccination last year in 2023. Despite the challenge we face, the introduction of gender-neutral vaccination in 2023 has shown promising results. Several regions have reported notable progress, especially in reaching boys who were included in the vaccination program for the first time. For example, in some regions, the coverage rates for boys exceeded the initial targets. This is encouraging, reflecting our success in community outreach and awareness efforts. For girls, as you asked, we also saw a significant improvement in coverage rate compared to previous year. Nationally, we achieved a vaccine coverage of almost 60% on girl and almost 30% on boy for the first year, which marked a substantial step forward in our effort to protect both genders from HPV-related diseases. However, while these improvements are encouraging, there are still disparities in coverage between regions that we need to really address. Looking ahead, our priority is to build on this positive trend and ensure that we continue to close the gap where coverage remains lower. Over to you, David.
Thank you, Bryce. Could I just final question for you there? What does the future look like for Cameroon with HPV prevention? Because I think, you know, from what you're saying, the way that this is financed, for example, is unique in some respects. So I would imagine that might be one of the challenges ahead as part of this.
Yes, of course. Looking ahead, our priority is to build on, first of all, this positive trend to ensure to continue to close the gap in coverage, as was mentioned before. And we based on the recommendation from the National Advisory Technical Advisory Group on Immunization in Cameroon, we have outlined several key actions. Firstly, we must strengthen community engagement and social marketing activities, promoting the importance of vaccinating boys and girls is crucial to overcoming misconception and ensuring that families understand the benefit of HPV vaccination for all children. Secondly, it's essential to motivate healthcare workers to continuous training on the importance of gender-neutral vaccination. This is a problem now we are facing now. This will empower them to effectively communicate with families and encourage vaccination uptake. And then to address also, as I was mentioning before, vaccine hesitancy, we must deliver clear and transparent messages about the safety and the benefit of vaccinating both genders. Engaging communities in this advocacy will be critical to build trust and overcoming resistance. Lastly, we need, as you were asking in your question, to advocate for sustainable fundings for vaccinating boys. And I can tell you that we have a support of Gavi for girls, but not support of Gavi for boys. All the vaccine provided by Cameroon was fully funded by the government. So as you can also imagine, it's heavy for our country who is a low middle income country. Thank you very much.
Thank you, Bryce. I mean, we now open up to the floor for I've seen some questions have come through, but if you do have questions for our panelists, do put these, you know, do ask them in the chat, and we can attend to them. I saw a comment in terms of HPV and infertility. There was a paper earlier this in the summer, I believe, that was speaking to this point around males and infertility in regards to HPV. I think it's too early to say at this point. It was a newspaper headline I'd seen rather than a paper. Perhaps someone in the comments can refer to that one. Other comments that we've had coming through. Let me just take a look. Where exactly is the HPV virus harbour in men for them to be carriers? I mean, the best way to describe that I've heard described HPV was at an International Anal Neoplasia Society meeting in the Netherlands about 5 years ago, in which one of our Dutch colleagues asked us to imagine HPV as if it's like glitter. And as everyone who's touched glitter knows, it gets absolutely everywhere. You know, you can touch some glitter on some wrapping paper or something like that, and 3 days later you'll find it behind your ear or on your big toe or whatever. And that's what HPV can be like in terms of those moist membranes in the bodies in males. It would be the oropharyngeal area, penile area, and the anal area. Questions in the Q&A. Thank you, Jim. And I'll move backwards from there. It's been answered. To Ian, your question. Early on in the UK, the issue of herd immunity was adopted. Why has this changed now? Ian, that's a great question. And I think, Peter, you can perhaps relate to this. I feel when we were making this case a decade ago, the herd immunity angle of this was something that was important. And do you feel that that's changed in recent years?
I'm not sure that it has. I mean, the argument about herd immunity in the UK, and I know elsewhere as well, is that there's an argument, I don't agree with it, but there's an argument that if you vaccinate enough girls, then you'll protect the boys almost automatically. And obviously it's true that a woman who has been vaccinated can't be infected with HPV and can't pass it on to a man. That's absolutely correct. But at the same time, we're never going to achieve 100% vaccination. It's an impossibility. We'll do very well if we get to 90%. So there's always going to be 10% at least of women who will be unvaccinated and potentially can carry the virus and pass it on to men. But of course, there is also a very significant group of men, and that's men who have sex with men, who are totally unprotected by a girls-only program. So even if we had 100% vaccination rate in girls, if it were even possible to achieve that, the men who have sex with men, that community would still have the virus. I mean, there would still be cancers in that community caused by HPV. So the only way, in fact, we can eliminate this from the whole community is to vaccinate everybody. And I think that argument still applies.
Yeah. Salomé, it looked like you wanted to come in there.
Yes, I want to weigh in there, and I want to say that I think this whole, narrative started obviously with the elimination of cervical cancer that is a global problem. But we have not, and yes, the cervical cancer rates are the highest, of all cancers. But we actually have not started, and Peter actually in his presentation has started indicating how the increase of other cancers is now happening. And that is effectively, so when we start talking about HPV, HPV doesn't only affect women, it affects men and women. And that, I think, is the basic argument. So WHO started a strategy specifically for cervical cancer elimination. And that is where the concept came in of the herd population, and we need to vaccinate girls. But it was never at that stage, and that's my argument, that it's never really looked at the broader picture of other cancers and other diseases.
Thank you, Salomé. I've got a question here from Jimmy, which is asking about promotion of the vaccine. Perhaps, Bryce, this is one for you. In terms of the promotion to parents of boys as well as of girls, are there any restrictions around promoting the immunization to children? Is that something that you can speak to, and what the scenario has been in terms of the education efforts undertaken in Cameroon to that effect?
So I was mentioning before, I was saying that we started with HPV vaccination program, focusing only on girls. We started by a demonstration phase in 2014, and we decided to move to gender-neutral vaccination in 2022, the almost 9th year. So our primary communication was focusing on cervical cancer. And I can even tell you that the HPV vaccine was called Vaccines Against Cervical Cancer. And when we decided to move to gender neutral, it was very difficult for parents to understand that. It's now allowed to the boys to get this vaccine. It's very challenging. And the problem that we are facing now is continue. And we need to rebuild our messages to convince parents of boys to get your children get vaccinated. It's a problem. Over to you.
Thank you,
Can I
Bryce.
just come in here, David, just to add that I think in terms of sort of public education and improving vaccine confidence, I think that the role of healthcare professionals is absolutely critical here in terms of the one-to-one communication they have with young people and their parents and carers. I think in many countries where we've seen a fall in vaccine confidence, where there's been a kind of crisis, we saw this in Ireland, for example, that was partly because many healthcare professionals were giving wrong information, were giving misinformation to people about the safety of the HPV vaccine. And I think if we could actually focus more on training medical professionals about vaccination, about HPV specifically, they would play an incredibly important role in changing opinion on this. And of course, what's crucial is that those professionals understand the case for vaccinating boys as well as girls. I think if we could focus more on medical education and continuing professional development for doctors, nurses, and so on, we would actually make more progress more quickly. And in fact, there's been some really interesting work done by the European Cancer Organization in Europe, work funded by the European Union, to look at how to develop new training programs, online training programs for healthcare professionals. And I think if we had more of that, if it was available in more languages and adapted to different cultures, different types of health systems, I think we'd make more progress more quickly.
Thank you, Peter. Got a question here about one dose HPV. Oh, sorry, Salomé, do you want to come in?
Just on that, and maybe also in terms of the whole aspect of education. If we go back to the HIV, the start of HIV, what was the success of the program there? It is absolute education, you know, in terms of how HIV is transmitted. And yes, there's a very broad community, and we have continual education and education around HIV transmission. What we have not done, and that I think is actually very important, is we have not done anything about how HPV is transmitted, and the fact that it is boys and girls, and what also is the difference between HIV and HPV. And that is, in fact, a very, very important aspect that we are not actually doing in terms of educating our communities, bringing that out and having the conversations within our communities, having the conversations with the younger generation, because that's in essence where that conversation needs to happen, the difference between the two and how it is transmitted, and then in essence how it can be prevented, and making those linkages.
Thank you, Salomé. And I've got a question for yourself and Bryce here around HPV one dose immunization strategy. Could you remind us what the current prevention program is in South Africa? Is it 2 doses or 1 dose?
So it is 1 dose. We've moved over to the 1 dose. So according to the WHO strategy, we've moved over to 1 dose. However, we will remain, so if you are HIV positive, you will remain with the 2 or 3 dose vaccine, you know, so that is important, that it's not just 1 dose for everybody. You need to actually also have a look and see what is your HIV population and what would be the impact. And that is, I think, where Bryce makes a very important point there, and that is that Gavi at this stage of the game is funding the Gavi countries, meaning only the goals-only program. And it then means that our governments, if we want to move over to gender-neutral vaccination, we then need to, countries have to fund that out of their own pocket. And that's where the whole question of affordability of vaccines come into play.
Thanks, Salomé. And Bryce, can I hand to you there on one dose HPV vaccination in Cameroon?
Yes, first of all, I want to emphasize that we started our national immunization program with 2 dose vaccine regimen. So we move on 2023 to 1 single dose following the recommendation of SAGE WHO. And we introduced at the same time on January 2022 the gender neutral vaccination. So this was an opportunity to have vaccine and to give them to boys also, I think.
Thank you, Bryce. Matanda, I see your comment. How can social media, existing community groups be leveraged more effectively to reach diverse populations with accurate information about HPV and the importance of gender neutral vaccination? Perhaps I can make a comment there. I think it's a really interesting point, and I think as we learn, as hopefully the point's coming across, there's a nuance and complexity to this conversation at times, whereas social media is aimed at simplicity, and that means we can fall back on previous knowledge, or the stakeholders that are putting out this information aren't necessarily as well educated and well versed as perhaps a clinician is, or caregivers or clinicians within this space. So it is difficult. There's, I mean, I don't know if our panelists have any comments there about how can we leverage those groups, but I think in short there is who do we get our information from is a question that we should be asking ourselves. If I was looking for financial information, I would speak to an accountant. If I was looking for legal information, I would speak to a lawyer. If I was looking for solid and dependable medical information, I would be speaking to my doctor, nurse, family clinician to get that information. I don't know if anyone else had some comments there.
Well, I just add, if I may, that I think social media is a key battleground for ideas around, or for misinformation and good information around HPV vaccination. We know that a lot of the crisis in confidence around the vaccine is actually driven through social media. And there are some bad actors out there who are deliberately spreading false information and confusing people and raising concerns about safety that we know aren't real. So I think we have to have a presence. People who share the view, as we do, that HPV vaccination is essential, have to actually contest those or challenge those false arguments wherever they arise. I think social media is one of the sites we have to do that. But I think your point is very well made, David, that there is no substitute for good face-to-face advice from clinicians who understand these issues and know what they're talking about.
Yeah, I mean, there's a brilliant comment here actually from, and I hope, forgive me if I'm pronouncing your name wrong, Lindelwa. The conversation's messaging should be the same, one global message, so there's no disjointed communication around HPV. And actually, in the global context, there are different conversations going on in different countries. One country might be talking about the prevention of all HPV cancers, another might be talking only about HPV in its context of cervical cancer. So what does that mean when it trickles down the tree to the front line and we talk about HPV prevention strategies? What do we mean by that? And that's unfortunately, we've ticked on to 14:59, and I think we could probably sit here and talk here for another couple of hours if we wanted to. I'm afraid we're going to have to draw our session to a close. Ladies and gentlemen, you've heard the case for global call for gender neutral HPV vaccination. You've heard some wonderful insights from Salomé and Bryce. We're incredibly grateful to you for joining us today, and to Peter for running us through the case for action report. If you do wish to find out more, you can do so via the website. That's endhpvglobal.org. So if you or your organisation does wish to join the 30 others who have already endorsed that case of action, you can do so there. You can get in touch with us directly. So thank you to you all for your attendance. Thank you to our panelists. Have a lovely rest of your day. Take care. Bye.